I would also like to thank HPBA for the invitation to do this debate, and I was equally intimidated when I heard it was Dave Iannati, because Dave is such a smooth talker. You can show no data, and you think you've seen data, and you've already decided. But I'll give the argument against. I have nothing to declare. So why are we talking about ablation when we reset? Let's go back to the rules of life. Why would we ever think about being number 2 when we already know we're number 1? We've known for years and years and years that resection is an effective treatment for colorectal liver metastases. And we've known in more recent years that resection margins aren't as important as we thought they were, that a very minimal resection margin is enough. And we've started to throw away a lot of the conventional indications for liver surgery and become a lot more adventurous, and this is something that I've spent my life doing over the past 25 years or so. So the limits of liver resection are disappearing. As long as we can get complete tumor removal and leave a sufficient future liver remnant, then we can do things very effectively. For instance, if we're worried about the liver remnant, then we can grow the liver remnant by techniques such as portal vein embolization. Many of you who know me know that I haven't been a fan of portal vein embolization until recent years, when the livers have become so chemotherapy treated that we've had to use it a lot more over the recent years. And we've got 2-stage resection. We all know about that for bilobal metastases when there is an inadequate remnant, with resection combined with portal vein ligation, and then 2nd-stage resection. And we know that these techniques are associated with very good outcomes for patients with advanced colorectal liver metastases. And there's been a lot of talk, obviously, in this Congress about ALPS, about the association of parenchymal transection with portal vein ligation, and then a few days later completing the resection after hypertrophy of the remnant. And people have worried about that a lot. It's been refined a lot. And the recent LIGRO trial has shown that ALPS is not only safe these days, but it's actually superior for many patients compared to 2-stage resection, because of a higher chance of getting the 2nd stage done, and with comparable outcomes, at least in the short term. And Dave will say we're being far too invasive with liver surgery, but he's an excellent laparoscopic surgeon, and he knows that we can do a lot laparoscopically or robotically and make it less invasive. So let's get to the point. What about this debate? The new kid on the block versus the giants of liver resection. Let's take a minute to consider this new kid on the block. And why am I arguing against Dave Iannati? Well, Dave is not only an excellent surgeon, he's a renowned chef as well. Many of you, I'm sure, will know about Dave's really superb cookbook. What I'm worried about, Dave, is why you're venturing into microwave cooking, because it looks pretty good, doesn't it? But I think we all know what the reality is. So let's take a look at the data for recurrence rates, outcomes, and so on for the different types of ablation versus resection. We were all very excited 15 years or so ago when reports were coming in from MD Anderson of large trials of patients undergoing resection plus or minus ablation or ablation alone. Here, a very large series of patients with 348 patients with potentially curable metastases going on to resection, or if resection wasn't completely possible in their view, then ablation with resection or ablation alone. But the results were disappointing. Whether it was resection with ablation or ablation alone, looking at overall survival or recurrence-free survival, they just weren't matching up to resection. And this, of course, was radiofrequency ablation. A couple of years later, Tom Malloy from MD Anderson looked at further results and showed categorically that resection was superior to ablation, both in terms of disease-free survival, local recurrence, and overall survival. I think we should look at the conclusion of that paper, Dave. The first thing that Tom said was that the survival rates for resection were increasing, and in that small series, 70%. Very impressive. With radiofrequency ablation, for solitary metastasis, there was a high local recurrence rate. And this was even true when the tumors were less than 3 centimeters. In fact, he went on to say that every method should be considered to achieve resection of a solitary metastasis, including referral to a specialist center, extended hepatectomy and chemotherapy, rather than ablation. So where have we come to now? This is 12 years later, a recent meta-analysis released this year, looking at that data and some of the other papers, but again, showing clear trends towards resection rather than ablation. And this is microwave and RFA, although largely RFA, I will admit. And this corroborates previous systemic analysis of studies done 10 years ago, which showed that resection was superior for multiple metastases or solitary metastasis, although there was a suggestion that for tumors less than 3 centimeters in size, perhaps a randomized trial should be done, but it hasn't been done. So one of the big problems, obviously, about ablation is local recurrence, and that seems to be directly related to size. And in the smaller tumors, I agree with you, Dave, percutaneous is not as good as laparoscopic. If we're going to do ablation, we should be doing it surgically. Let's not let the radiologists take all of our jobs away. And a subgroup analysis suggested pretty strongly that the laparoscopic or open approach was better than percutaneous. Looking at microwave, again, the results are not as good as resection, but there has been shown to be reduced local recurrence with microwave compared to RFA. So I think microwave is probably the best we have currently. What about a randomized controlled trial? There was one reported in 2000, looking at the early results of microwave versus resection. Looks pretty good, doesn't it? But there's always a but. Local recurrence rates weren't reported. There was no intention to treat analysis reported. The randomization wasn't clear, and there was a high dropout rate. So we just don't have the data. So, do we need a randomized trial? I think we do. There are a couple out there. Dave's mentioned this one from the Dutch group, which is being extended into other countries, including North America. And this looks very hopeful that we might get some data from this. That there has to be at least one tumor which is less than 3 centimeters in size and eligible for resection or ablation, and other tumors have to be treatable. But we have no results. We tried to do the same thing in the UK last year, looking at patients with up to 5 metastases, primarily elderly or frail patients who were eligible for resection or ablation, but it closed. We've absolutely failed to recruit. So, where are we? We don't have a randomized trial. There's an imbalance of characteristics in the trials where ablation is put against resection, and we have no data currently that's out there for ablation of resectable lesions, because we all believe that resection is better. So I think resection remains the gold standard. Ablation, I'll give you, may have a small role for, say, a small central tumor, a frail patient, an elderly patient. But I think resection is definitely superior to ablation in terms of both survival and in terms of local recurrence in particular. Ablation, I agree, Dave, could be complement for resection, but it's not a treatment on its own. It's not going to replace resection, not in my lifetime, I don't think. So where are we in this battle of titans? New kid on the block or the old boys of resection? I think let's go back to the kitchen. What do you want tonight? Do you want the classical approach or the microwave meal? I know which one I'm having. I think the battle's done. Now, before I conclude, I'd like to thank our senior fellow, Philip Cron, who helped me put a lot of this together. I'm very grateful for that, Phil. Thank the organization for asking me to do this debate, but also remind you, please come to Amsterdam next year for EHPBA. Thank you very much.